Module 19, IDR in cases with gingival recession. Now it's time to focus on cases that presented gingival recession, slight or large gingival recession. Our target here is to restore hard and soft tissue damaged using, in most of the cases, triple graft harvest from maxillary tuberosity. This is our main indication to treat cases with bone loss and gingival recession. Let's follow this step-by-step treatment on this clinical case. This first one, this patient presents a small gingival recession. In this case, it was used a cortical cancellous graft to restore hard and soft tissue damage. This patient presents two central incisors condemned to be extracted, and we had an uneven of gingival margin, a gingival recession around 1.5 mm in the right central incisor. And we have a good amount of available bone beyond the root apex, as you can see here. But to make things a little bit worse, this patient presented a thin periodontal biotype. In this case, we are going to share with you what are the limitations of using bone graft to change the soft tissue in the corneal direction. Here we have the clinical view and the CBCT scans. It was confirmed that in both sides, in the right and the left, this patient lost completely the buccal wall. And we decided to start for the left side. The tooth was extracted, applied minimally invasive procedure. The implant was placed in the palatal wall hemorrhage. It was confirmed the buccal bone wall loss. After graft is being harvested from the left tuberosity, it was reshaped according to the defect configuration, and we also matched the cervical portion of the graft with the outline of the gingival margin because our goal here is to restore the bone architecture. This is the main goal of the IDR procedure. And the bone was packed to fill the gaps, just small particles, only particulate bone, as you can see here. We manufactured the provisional restoration, and here it was promoted the gingival sealing because we were expecting any change in the soft tissue in the corneal direction. And of course, we performed here a slightly contour in the proximal aspects, not only in the buccal, but also in the proximal aspects of this provisional restoration. And how about the positioning of the implant and graft? This is one of the topics to be discussed with you in this clinical case. In the left side, the implant was placed 3 mm from gingival margin in the apical direction, and the bone graft was placed 2 mm from gingival margin, better saying 1 mm over the head of the implant. 3 months after the IDR procedure was finished in the left side, we treat the right side. The periodontal pocket was around 9 mm in depth. We still have an uneven of gingival margin, and through this CBCT scan, it's possible to notice the total loss of the buccal bone wall. It was confirmed the loss of the buccal wall through this picture. The implant was placed in the palatal aspect, and we left a gap around 3 mm at the buccal aspect. The bone graft was taken from the right side, and here you can see after bone graft manipulation. And pay attention that at the buccal aspect of this graft, at the cortical layer, we have a high vascularization. After bone graft insertion, the particulate bone was condensed, and we fill this area all around the head of the implant, and we left bone graft over the implant platform. I want to call your attention here to the graft vascularization, not only in the cortical cancellous bone, but also in the particulate bone. And take a look at the bone graft was placed 1 millimeter over the head of the implant. Now it's time to take the decision. What to do right now? We still have the gingival recession, but how to do it? How to manage? How to put the soft tissue in the original position? We have some options of treatment. Maybe we can do a connective tissue graft, the use of a triple graft. Maybe we can open a flap using a flap surgery or the flap position in the corneal direction. One of the first indications that I recommend you to use in clinical case like this that we have is slightly gingival recession is the use of a triple graft. The outcomes should be more predictable when we use a triple graft instead of using only cortical cancellous graft. Our goal here in this clinical case is just to let you know that it's possible to change the position of the soft tissue in the corneal direction when we use only bone. We manufacture the provisional restoration. Let's have a look at the emergence profile. And we install this provisional restoration regardless of the gingival recession. And we have a gingival recession around 1.5 millimeters in height. But the finishing line of this provisional restoration was placed at the same level of the gingival margin of the contralateral side. Regardless of the gingival recession, doesn't matter. We left here what we call a soft tissue gap to promote a soft tissue accommodation in the corneal direction. And we built a concave contour at the proximal aspect of this provisional restoration, at the buccal and the proximal aspects. And how about the position of the implant and graft? The implant was placed 1.5 millimeters from gingival margin in the apical direction. Remember that we have a gingival recession around 1.5 millimeters. Now it's time to compensate the biological width. And the bone graft was placed half millimeter on gingival margin in the apical direction, just underneath the soft tissue. And we installed this provisional restoration over the implant with ideal emergence profile. Let's pay attention to this picture. This is the expected gingival margin position. Here you can see the gingival recession. The bone graft was placed half millimeter below gingival margin. And the implant was placed 1.5 millimeters in the apical direction. From this area, from the head of the implant to the cervical area of this provisional restoration, we should have around 3 millimeters. We supplied blood from the tuberosity. We collect blood using a syringe, and we inject this blood in order to fit completely this area from the gingival margin position to the cervical area of this provisional restoration. As you can see through these pictures, from the frontal view, side view, and the occlusal view. And we wait for 5 minutes until we got the blood clot. That was the right moment that we send the patient home. Now let's have a look at the evolution of the regeneration process of the gingival tissue. What's gonna happen with the soft tissue? This is the post-op after 7 days, a month after the procedure is finished, after 2 months, and after 3 months. Pay attention that the soft tissue moved in the corneal direction. We have the corneal displacement of the soft tissue. After 4 months, how about the biological width? The biological width was retrieved. We have 3 millimeters from gingival margin in both sides, the right and the left. The impression was taken, the final screw retained porcelain restoration were made, and the crowns were delivered. Here the post-op after 2 years, we have the soft tissue maintenance around these 2 single crowns around the implants. 4 years post-op, remember that we have to check the maintenance of the color, the texture, and the volume of soft tissue. And this CBCT scan was taken after 7 years. Take a look here. Here we have the connection between the remaining bone and the bone grafted in the left side and here in the right side. So we still have the 3 millimeters of grafted bone, new buccal wall in both central incisors, and the bone graft that was placed above the implant platform still remains in the same position. So we got hard tissue stability. Just to keep in mind how everything started, we had the buccal bone wall loss in both central incisors. Here before and after, we had an uneven of gingival margin, and now you can see a symmetrical gingival margin position. But not only that, we have the improvement at the papillary height position. This is the follow-up after 9 years. I can say that we got a soft tissue stability around the implants. And how about cases that presented large gingival recession? In cases like this, it's mandatory to use a triple graft. It's a little bit different the other graft that we discussed before, because this graft has connective tissue along with corticocancellous graft in one single piece. This is a triple graft, a graft with 3 layers. And here the first article in the international literature published by my team in 2009. Here for the first time it was written an article that recommended to do it all in one single procedure without opening the flap, doing tooth extraction, implant installation, bone and soft tissue graft using triple graft from tuberosity plus immediate provisionalization. Everything solved in one single procedure. Here another article that was published in 2014 at the Journal of Prosthetic Dentistry. Let's have a look at this case. This patient presented a high smile line. We have a breakdown in aesthetics. Here we can see not only uneven of gingival margin, but a large gingival recession. A gingival recession around 4 millimeters in height. And it was missing completely the buccal wall. That's what we consider a bone defect type R4. The tooth was extracted. You can see here a thin periodontal biotype. Because of the gingival transparency, you can see the periodontal probe. The implant was placed 1 millimeter from gingival margin in the corneal direction. Remember that we have a gingival recession around 4 millimeters. And our reference is the enamel cement junction of the opposite side, the contralateral side, the left central incisor in this case. And here I want to call your attention to the hard and soft tissue damaged. Let's focus in this picture. I have here many topics to be discussed with you. First of all, let's take a look at these lines. The red one represents the gingival recession. The blue one, the implant position. The green one, the expected gingival margin position. From this area, from the blue one to green one, we should have around 3 millimeters in height. And the finishing line of the provisional crown was placed at the same level of the gingival margin contour of the opposite side, regardless of the gingival recession, doesn't matter. And let's focus in the emergence profile of this provisional restoration. This space was left. It was performed here and under contour at the buccal and the proximal aspect. This is what we call a soft tissue gap to allow the accommodation of the connective tissue of the triple graft. Now let's focus on the incisions. Here it was performed 2 incisions at the papillary level, and 2 more divergent incisions following the gingival recession pattern. This second incision will guide us the height of soft tissue to be moved in the corneal direction. To harvest a triple graft from the tuberosity, we need to access this donor area clinically, radiographically, and through a soft tissue CBCT scan. And through soft tissue scan, we can see here accurately the height and the width of soft tissue available. And of course, the height and width of bone tissue. Let's have a look at the step-by-step of triple graft harvesting. The first step is the incisions. One of them is parallel to the distal aspect of the last molar, and 2 more perpendicular incisions touching the crestal bone. The step 2 is the flap division, leaving a connective tissue layer covering the bone. Now it's recommended to leave between 1 and 1.5 millimeters in thickness of soft tissue covering the bone. Step 3 is the osteotomy. It's mandatory to use a straight chisel for the osteotomy, and the chisel has to be placed as perpendicular as possible to the bone, right after to go deeper 1 or 2 millimeters. The chisel's angulation is modified according to the desired size and width. After going till the length planned, the bone was fractured. Now it's missing just to release the connective part of this triple graft. This is why we are doing a posterior incision. And here you can see the triple graft. The triple graft has connective tissue, cortical, and cancellous bone in one single piece. But when we harvest a triple graft from tuberosity, we always need to harvest more bone in order to be crushed to fill the gaps. And here we have an histological section performed by Dr. Luis Antonio Violins Dias Pereira from Unicamp University in São Paulo. You can see the connective tissue, the periosteum, the cortical and marrow bone. So we have 4 sources of the nutrition ready to be transplanted from the donor side to the receptor side. After graft harvesting, we reshape this triple graft and we use micro scissors to reshape the connective tissue and the rounder to reshape the bone tissue. This is a triple graft. Now we crushed the remaining bone using the same tool that was used to reshape the bone tissue, a rounder, and we reduced as much as we could the size of the particles. The ideal position of the triple graft is having the connective tissue turned towards the soft tissue and the cancellous part to the implant body. But in between the cancellous part of the triple graft and the implant, it's recommended to insert particulate bone. When we use this concept using 4 incisions, it's recommended that the first step should be the particulate bone insertion and the second one, the triple graft insertion. Here we are seeking the right position of the triple graft. After we got it, 1 stitch was enough to stabilize the triple graft and 2 more stitches in each papilla. And pay attention that we left the gingival margin position in the same level of the opposite side. We don't need to overbuild this area. Let's have a look at the evolution of the regeneration process of the gingival tissue. This is the post-op after 10 days. And here, after 4 months, after soft and hard tissue is being healed, the biological width was retrieved. We have the reestablishment of the biological width, and we have now 3 millimeters from gingival margin. Remember that the implant was placed 1 millimeter from gingival margin in the corneal direction in the day of the surgery. And we have a thick soft tissue around the implant. And I can say that we have the biotype conversion. We started with a thin periodontal biotype, and now you can see a thick periodontal biotype. After the impression was taken, we manufacture here a Procera customized abutment. And take a look at the leveling of the gingival margin. But not only that, the anatomical contour of the gingival margin is very similar to the opposite sides. The final crowns were made. It was cemented over this customized abutment of the implant and the natural teeth. And here you can see the balance between the gingival margin and the papillary height position. 2 years post-op, remember that we started with a breakdown in aesthetics. We have an even gingival recession in the right side, in the right center incisor, and we have imbalance between gingival architecture. And now you can see not only an harmony of soft tissue, but the balance between the lips, the gingival architecture, and the final restorations. 10 years post-op, the papilla still remains in the same position, and we have the leveling of the gingival margin. And through this CBCT scan, you can see the 3 millimeters of the bone grafted. It's still stable after 10 years. And how about cases that presented gingival recession plus bone loss plus infection? Let's follow this case. We have a huge infection in this right canine, total loss of the buccal bone wall, and through this 3D image, you can see the extension and the severity of this bone loss in height and width. So we have to treat this case as an R4 defect. You have to restore hard and soft tissue damaged. It was made here a prototyping. Over the prototyping, we measure the width and height of the defect. In the day of the surgery, after tooth extraction, you can see here the tissue shrinkage at the buccal aspect, a poor quality of soft tissue, and the total loss of the buccal wall. The implant was placed. A very good implant primary stability was obtained, around 40 Newton centimeter. And take a look also here, the tissue elasticity, a poor quality of soft tissue. From the tuberosity was taken a triple graft and particulate bone. We reshaped the graft according to the defect configuration, but in this case, over the prototyping, after this graft was matching the defect, it was inserted in the receptor side, in the patient's mouth. First of all, we introduced the triple graft in the right position. This graft was stabilized by juxtaposition, by a very good adaptation between the graft and the remaining bone. And it was packed between the triple graft and the implant particulate bone, as you can see here. We installed the provisional restoration. This graft was exposed beyond the gingival margin, just a little piece. 3 months post-op, soft tissue is completely healed. The impression was taken, a screw retained porcelain restoration. Here you can see the maintenance of the anatomical contour of soft tissue. The CBCT, after 3 years, the bone tissue, the new buccal wall, remodeled and is still stable. Just make a comparison that we have a severe bone loss, and now we can see the presence of bone all around the implant. Remember that in the beginning we have the tissue shrinkage right after tooth extraction due to a poor quality of soft tissue. And now you can see a relevant thickness of soft tissue around the implant. This is the post-op after 5 years. We have the maintenance of the anatomical contour of soft tissue and the gingival margin and the papillary height position. And here the CBCT scan. Let's take a look at this image. We have around 3 millimeters of bone at the buccal aspect, the new buccal bone wall, and a relevant thickness of soft tissue. The bone graft that was placed above the implant platform remodeled and is still stable above the implant platform. That's amazing. And I can say that we have only vital bone tissue around the implant. You can see through the sagittal view and the axial view, the maintenance of the volume, the thickness, and the contour of the bone tissue. And remember that the soft tissue, it still remains in the same position due to the presence of the new buccal bone wall. This article was published in 2017 by the International Journal of Aesthetic Dentistry about this topic, the use of a triple graft to restore hard and soft tissue damage in one single procedure without opening the flap. In this module, it was possible to notice the importance of using a triple graft from the tuberosity to restore hard and soft tissue loss. Summarizing, the triple graft can be applied in cases with loss of volume of soft tissue, a combination of severe bone loss and uncontrolled infection, and also in cases with small or large gingival recession.